Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, thank you to Dr. Bob Harrington for doing another talk for us today. Bob is part of our expert ATC ECHO panel here and also director of our Madison Clinic, and Bob's going to talk about controversies with the new HIV primary care guidelines.
Good morning, everyone. I thought I'd review these guidelines. So the primary care guidelines for the management of HIV-infected patients were just republished in 2013, in November 2013. So the references up there and you can peruse them. And I thought I would run through what are the content of those guidelines and then maybe highlight a few things that were a little surprising to me. Much of the data I think is pretty well known. So I'll talk about an initial evaluation, briefly just touch on OI prophylaxis, and then talk about follow-up care. I'm not going to talk about ARV guidelines. Hillary just mentioned to us that the newest iteration of the guidelines came out today, so maybe we can touch on those things at the end. And then follow-up care, including laboratory care, cancer screening, vaccination, and STD and metabolic disorder screening. An initial evaluation. This is a made-up case of a 23-year-old gay man who presents after testing positive for HIV via a rapid test at a nightclub. This is his first ever HIV test. He's sexually active with men exclusively, has around 10 partners per year, and does not regularly use protection. He's well, has no symptoms. His past history is notable for methamphetamine use and STDs. He's a college graduate, works in retail, drinks too much on the weekends, smokes a half pack per day, and no longer uses illicit drugs, and his exam is normal. So just to review, what are the elements of a comprehensive HIV history and exam? It differs a little bit from what you might do for your non-infected patients. I think it's important to focus on the HIV testing, and many patients have had serial tests so that you can find out when their last negative test was and their first positive, and then time their infection and get some idea about the trajectory of their disease by knowing exactly when they got infected, if that's possible. If they've been infected for some time and know it and have been on antiretroviral therapy, then you want to know about their adherence, any drug resistance or drug intolerances that they've had in the past, and what their lowest CD4 count was, and then their their HIV zenith and set point again can help you track their particular disease course. Any HIV-related illnesses, obviously, and then any cardiac, renal, or hepatic disease history, since many of our patients have comorbid conditions involving those organ systems. TB risk exposures are important, of course, and then a travel and residence history to get some insight into whether or not they've been exposed to or infected with some of the dimorphic fungi like coccidioidomycosis in the southwest and histoplasmosis in the Midwest. Many of our patients do suffer from mental health and substance abuse problems, so getting an accurate history regarding those issues is important, as well as a sexual and STD history. And then the HIV status of their partner. You may end up talking about PrEP and ways to prevent the transmission of HIV from your patient to their partners. Finally, medications, looking for drug interactions if you're planning on starting antiretroviral therapy are key. And then part of the physical exam with particular attention to skin, mouth, lymph nodes, a good neuro and cognitive exam, an anogenital exam, and then paying some attention to any fat redistribution and looking for markers of liver disease. So also during this initial visit, you'll want to get some laboratory testing, most of which you won't have by the end of the visit, but you want to confirm that they're HIV positive, obviously, check a CD4 count, viral load, and genotype resistance testing, as well as chemistries, fasting lipids, a G6PD level. It's good to get while they're healthy, since a depressed level when they're healthy might put them at some risk for hemolysis if you were to prescribe dapsone or primaquine. Screening for latent tuberculosis with a skin test or an interferon releasing test. Toxoserology, syphilis serologies, again the ELISA for syphilis if there's no history of disease, and if they have a history of syphilis, then that's less likely to be helpful, and so marking the activity of them with a non-treponemal test like an RPR or VDRL. and hepatitis B testing. And this was called out in the guidelines that if they have an isolated core antibody, so surface antigen and antibody negative, but core antibody positive, it's worthwhile checking their hepatitis B DNA, looking for cryptic occult chronic Hep B infection. Hep C antibody testing and repeating that annually if they're at risk, so if they're IDUs or have multiple sexual partners. Hep A and CMV. I'm not sure we test CMV antibodies much anymore. Most of our patients, if they've acquired HIV, are likely to have CMV. But if you have somebody that falls into a low risk group, so not a gay man, not with many sexual partners, not an IV drug user, if you find out that they're CMV antibody positive, then you can avoid CMV positive blood products in the future. So what about the occult hepatitis B infection in those with the isolated core antibody? There's a lot of studies that have looked at this. One of the biggest was the Swiss cohort study. They follow about 35 or 4,000 HIV positive patients and identified 57 of those that had the isolated core. And they had serial blood tests in these individuals, and over time found that almost 90% of them did have HBV DNA detected in their serum. And the range in other studies is as low as 0.6, but up to again, over 80%. So much more common than I had realized, and perhaps worth checking in your patients that have isolated core antibody. So what about STD evaluations? Well, all women should be screened for trichomonas, and then men and women for GC and chlamydia. And anyone testing positive for any of those three should be retested in 3 months, not to look for a test of cure, but just because if you've had it once, you're likely to get it again, so due to high rates of reinfection. Cervical cancer screening, Pap smears, this is a little different than HIV uninfected women. Pap smears should be done on presentation with a repeat done 6 months later. And then if both those tests are normal, then annually for the life of the woman, which again is different than HIV uninfected individuals. And if you find any abnormality on Pap screen, then they should be referred for colposcopy. Anal cancer screening is pretty controversial. The guidelines say anyone practicing receptive anal intercourse or who has a history of genital warts, and women with abnormal Pap smears should have an anal Pap smear. Quality of the evidence behind this recommendation is moderate, and the recommendation was weak. And we'll talk about that and what to do regarding anal Pap smears in a minute. Then testosterone testing for men that have those symptoms might be of some value. So for cancer screening, again, some differences. Women should have Pap smears done annually. Mammograms for women, if annually, again, that's different than HIV uninfected people if they're over 50, and individualize those recommendations for women in their 40s. Colon cancer screening is no different than HIV uninfected people. But what about anal cancer screening? So it's a bit of a quagmire. On the left-hand side are reasons to do it. So there are high anal cancer rates, up to 137 per 100,000 among gay men. High rates of anal HPV and SIL in women with cervical SIL. High-grade SIL can progress to invasive cancer. Anal Pap smears can detect anal dysplasia with fair sensitivity. And IRC, if you have access to it, provides a safe and effective means to treat these lesions. And survival from anal cancer is much improved if you detect it early. So those are all reasons to do anal Pap smears. But anal dysplasia is unbelievably common. Over 90% of gay men who are HIV infected can have anal dysplasia, a smaller percentage of women. And anal dysplasia can regress spontaneously. So you could have someone with a grade 3 AIN who, next time you do an anal Pap smear, it's gone. Anal Pap smear specificity and their correlation with cytology is variable. And there is no evidence that anal Pap smears improve outcomes. And by that I mean there's no evidence that programs that use anal Pap smears lead to better outcomes from individuals who are eventually diagnosed with anal cancer. And finally, there's low availability of high-resolution anoscopy and IRC. We're kind of stuck. There are some good reasons to do it, but there's some problems with it, and there's no long-term studies that have really shown any survival advantage to doing anal Pap smears. This is what we do at our clinic. We don't do routine anal Pap smears. For individuals who have anal warts, or a history of anal warts, we recommend an annual digital rectal exam and regular anoscopy, not high-resolution anoscopy. For individuals with ongoing anal symptoms, we ramp it up a little bit and do semi-annual DREs and anoscopy. And for those individuals who have had anal cancer or have had anal dysplasia because they have a Pap smear that was done somewhere else or a long time ago when we used to do them at the Madison Clinic, or they had pathology sent on anal tissue that was sent in for anal warts that shows dysplasia, then we just started doing HRA at our clinic. Jeff Schouten, one of our longtime providers, was trained in the technique, and so now we have the ability to do that. We haven't opened up anal Pap smears to the entire clinic because maybe up to 90% of our gay men would have dysplasia, and we couldn't accommodate the need for HRA. So more to come. I think that every practice has to individualize their recommendations. This is just what we do at our clinic. So what about vaccinations? I think Dr. Dan already probably reviewed this in a session, and most of it is pretty straightforward. Influenza and strep pneumonia recommendations are as posted there. HPV for men and women, a little stronger recommendation for women between 9 and 26. And hepatitis A vaccine, recommendations are to test for seroconversion and revaccinate if they are non-responders, which was something I didn't know about before and haven't been doing, so thought that I should highlight it. And then hepatitis B vaccination, these guidelines recommend a higher dose, 40 micrograms of Recombavax rather than 20 for individuals who are surface antigen negative and whose surface antibodies are less than 10. And for individuals, again, who are isolated core antibody, if their hepatitis B DNAs are negative, then they can be vaccinated as well. MMR and Tdap and varicella are pretty straightforward. The guidelines also recommended considering a zoster vaccine in those individuals who are over 60 years of age, as long as their CD4 counts are over 200. So that's a little different than some other guidelines. So what about vaccinations? Just to mention that seroreversion with hepatitis A happens in about 10% of people, so perhaps it is worth checking to see if they're still immune. And the hepatitis B vaccine guidelines are different than the IDSA vaccination guidelines, which say consideration of the higher dosing. But note that there is better response rates at 40 micrograms than there is with 20. And there's also better response rates when individuals are on HAART with a suppressed viral load and at higher CD4 counts. So it's reasonable to delay until you get people onto therapy, provided they're not at very high risk for getting hepatitis B in the short run. And then, for those individuals with an isolated core, if they're HBV DNA negative, then vaccinate with the 3-dose vaccine series. I looked around to see if I could find any additional evidence on the zoster vaccine. It is listed as contraindicated in HIV-infected patients in the package insert and in the IDSA vaccination guidelines. But there is also this caveat, and I couldn't find the primary data, that there are preliminary results from the zoster vaccination of almost 300 HIV-positive people on stable antiretroviral therapy showing safety and immunogenicity. So maybe the guidelines are going to, the other IDSA guidelines are going to change soon, but for right now, there is this difference between the HIV guidelines and IDSA vaccination guidelines. OI prophylaxis. New folks to the group, we don't prophylax primarily for too many illnesses for PCP when individuals' T-cell counts are less than 200, less than 14%, or if they have another clinical reason to go on to prophylaxis, and we use Bactrim as the preferred therapy. For TB, we're not really preventing TB infection, we're preventing disease. So if someone is latently infected with TB with a skin test that's greater than 5 millimeters or a positive IGRA, then INH for 9 months. Toxo if your people are antibody positive and their T cells are less than 100. And then MAC, MAC, if their T cells are less than 50, then the macrolides are appropriate. So what about follow-up care? There are some differences, and they are also highlighted in the treatment guidelines that Hillary was just mentioning to us. So HIV RNA testing every 3 to 4 months, but this can be extended to twice a year for individuals who have been suppressed for 2 to 3 years. CD4 testing, which had been every 3 to 4 months, can be extended to every 6 to 12 months for those with good CD4 reconstitution, and that probably means a T cell count greater than 350. HCV antibody testing annually, so not just when they enter care, but annually for those at risk. Those would be IDUs or, I think, gay men with multiple partners. And repeat testing for tuberculosis if those who tested negative initially had low CD4 counts and whose T cell counts are now bumped over 200. And I'll show some data on that in a minute. Special testing as listed there. And then repeat genotype testing if there's been a delay between the time that they first came into your practice and had genotype testing and the time that you're going to start them on antiretroviral therapy looking for superinfection. And then vaccinations are pretty straightforward for follow-up vaccines for flu and strep pneumo. STD testing we've already covered, and then metabolic disorders or screening for them with blood sugars, A1C, fasting lipids before, and 1 to 3 months after starting antiretroviral therapy, and then bone densitometry for both postmenopausal women and men over the age of 50. This is data from, I think, Spain, where they looked at a longitudinal study of almost 1,000 patients at a single center and looked at IGRA responses in individuals whose T cell, this is by CD4 count current and CD4 nadir. And the point of the slide is to show that indeterminate results were more common at individuals with low CD4 counts, suggesting that the test isn't working very well at low CD4 counts and warrants retesting when their T cells are higher. And then this is data, I think, from Kampala, randomizing, or not randomizing, but stratifying people by CD4 count, and then a variety of different TB tests. This is the ELISpot test, the quantiferon, and then 3 levels of skin testing. And the point of the slide is, except for the ELISpot test, which seemed to perform pretty well no matter what your T cell count was, but the other tests, much lower likelihood of being positive at low CD4 counts than at higher CD4 counts or healthy control, suggesting that their performance isn't so great there and it warrants repeating when T cell counts are reconstituted. And then finally, well, what about superinfection, and should we be testing people for drug-resistant virus more than once if there's a big delay between their initial appointment and subsequent time when they get started on therapy? These are just a map of where superinfection has been reported from observational studies in North America, Australia, and Britain, and a few African countries, and then fewer still case reports of superinfection. But the point is that the reported rates in these different papers range between 0 and up to 7.7% per year. Most superinfections happened early after primary infection, but some happened as late as two years after their initial infection. So perhaps more common than we all think, and if there's been a significant lag time between patients who first come into your practice and then when you get them on therapy, that's something to consider looking for the acquisition of new transmitted drug resistance by virtue of HIV superinfection.